Clinical Pathology Conference. It is my pleasure to introduce Dr. Dilip Muduly, Professor and Head of Department of Surgical Oncology at AIIMS Bhubaneswar. Sir is an accomplished surgical oncologist with over 17 years of experience in complex oncology surgeries, research and medical education. He completed his MCH in surgical oncology from AIIMS New Delhi and received several prestigious honors, including the Pfizer Gold Medal, the Young Researcher Award from the Japanese Surgical Society, and fellowship from renowned institutional bodies such as UICC and ESS. With more than 100 peer-reviewed publications, Sir has made significant contribution to clinical research, particularly in breast, gastric, gynec cancers, and peritoneal surface malignancies. He is also actively involved in advancing oncology services and mentoring the next generation of surgeons. We are truly privileged to have him with us today. Without further ado, I invite Sir to begin the clinical discussion.
Thank you. I thank Dr. Ansel and Department of Surgical Oncology for giving me this opportunity. It is always inspiring coming here because my alma mater has been here, yes, and she's both. We spent here almost 11 years. I feel inspiring coming here and meeting people. Thank you. So coming to this case, this is a 70-year-old woman presented with generalized abdominal discomfort, which was associated with heaviness since last 2 months. She did not have any other symptoms. She presented into gynecology department for uterine prolapse. And one investigation was done which showed there is a mass in the abdomen. She did not have any symptoms related to bowel or bladder. No history of any addiction or allergy. No history of any weight loss or loss of appetite, no history of any addictions, no history of any familial malignancy, no comorbidities. And she did not have any symptoms of palpitation or anxiety, which is few. On examination was also general examination absolutely normal. No pyloric teres or lymphadenopathy. Vitals were completely normal. On systemic examination, only she had scar of previous cholecystectomy. There is no other organomegaly or mass palpability. Hematological investigation, renal function test, liver function test, and blood sugar were normal. Coming to CT scan, this was done in January. There was a 7 centimeter mass in the pararenal, in the paravertic area between the kidney and the aorta, below the left renal vein, and there was a thrombus in the going into the left renal vein and also in the left gonadal vein. So that was the scan given. This is the video they have given me. So I have done a screenshot of all the scans. So you can see this is the left renal vein, which is completely opacified. Just at the lower border of left renal vein, you can see there is a small hypodensity. So probably it is a thrombus. Then in the next cut, again there is a thrombus, but there is surrounding hyperintensity. So there is some contrast here, filling. In the next scan, there is a mass coming with 2 arteries. One artery, most probably this is the renal artery. There is another artery coming here. Probably it is upper polar artery. It is coming from the aorta. So next scan is showing the mass is increasing in size. With it is smooth margin on the medial side, slightly irregular on the other side. There is necrotic mass, hypodense mass with septations. and on the border you can see there is contrast. So probably it is enhancing or there is contrast looking there. In the next scan also similar, it is enlarging in size. Again in the next scan it is decreasing in size. So it is narrow above, narrow down, and in the middle it is larger. So you can see here there is contrast around with hypotenuse mass inside. In the next scan you can see again there is hypotensity in the middle and contrast around. Again in the next scan similar, you go to the next scan again, so the hypotensity ends. So there is a hypotenuse mass inside a vessel probably. Going back. MRI was done, that was done in February. There is no significant new information we can get from MRI. There was a multi-lobulated mass in the same area without any new findings. DTPS scan was done, that was showing bilateral non-obstructed kidneys, both the functions were normal. And if you can see the video of the CT scan. You can see this is the renal vein once, right? So there is a thrombus inside the renal vein. Now there is a mass, renal artery, and there is a mass. It is going down between the kidney and the aorta. So you can see the thrombus inside. So the kidney is free, the pancreas is free from above, duodenum is free, aorta is free, and posteriorly psoas is free. So we can see, next. Preoperative biopsy was done, core biopsy from the left parotid mass is showed, fibroadipose collagenous tissue along with thick walled blood vessels. That was the finding given. Coming to differential diagnosis, you can go, actually the CT scan is giving lot of information, so we'll go back again and see. Again we'll go. So there is a mass in the left parietal space with contrast around. Either there is a peripheral enhancement or there is contrast on the periphery with a mass inside. Probably it is looking like a mass inside the left renal vein with contrast on the borders. However, the mass is not enhancing. Probably it is a low-grade tumor. That is why it is not enhancing. Or it is a blind thrombus. However, blind thrombus cannot be that large. It has to be small. Mostly, they do not grow to this big size, 7 centimeter size. So, coming to the differential diagnosis, what I feel I have divided into two groups. One group is there is a lesion which is compressing or infiltrating the gonadal vein from outside. So, renal vein where it is joining, it is actually, there is a mass which is spindle shaped, enlarged here, narrow above and narrow down. It is compressing the vein from outside. And there is antegrade, because of obstruction, so there is both antegrade and retrograde, both there is a thrombus on both sides. Another possibility is there is a mass inside the vein. The septi are actually the thrombus, between the two thrombus there is contrast going in, so it is looking like septa. And in the middle there is either there is a blind thrombus or there is thrombus with tumor, so tumor thrombus. And there is both on the proximal side and distal side there is thrombus enlarging. So coming to the first possibility, there is a tumor outside the renal vein and it is compressing the gonadal vein. So there are a lot of differential diagnoses: retroperitoneal lymphoma, retroperitoneal sarcoma, any form of sarcoma, pancreatic tail tumor, paraganglioma, pheochromocytoma, cyst, or neurogenic tumor. Coming to one by one, lymphoma is a least possibility because there is no other symptoms. Patient doesn't have any type B symptoms, no lymphadenopathy, or only singing. Tuberculosis is also one possibility. It can present like this. Although uncommon to find a single node without any disease, any symptoms. Next is retroperitoneal sarcoma. There is a mass effect on the vessels that you can see, and it is in the retroperitoneum, slow growing mass. There is no pain because many of the sarcoma may not present with pain. It's small tumors. However, there is no fat component because liposarcoma is most common here, and the biopsy what we have seen is not suggestive. Pancreatic tail tumor with secondary venous compression is possible. However, the pancreas is free. If you see, it is not free, but it is closely abutting the lower body, not in the tail or body of the tumor. Paraganglioma is a possibility. However, paraganglioma are hypervascular, although they encase the vessels. However, there is no symptoms. The non-functional paraganglioma can also be asymptomatic. Cyst can be a possibility, but there is no patient doesn't have any symptoms related to bowel. Also, on imaging, bowel is free. And another rare possibility can be a cystic schwannoma, depending on the location. However, the patient doesn't have any symptoms, no pain or any discomfort in the back. Coming to the second one, that is, there is a tumor inside and inside the renal vein, and it is obstructing the renal vein. So one thing I have forgotten to tell you, we will go back again to the CT finding. Yes, you can see this is gonadal vein which is expanded, and in other side you see there is no enhancement. The IVC is also not enhanced. It means can go here only. So there is enhancement here. However, there is no enhancement on the IVC or the left renal vein. It means it may be that there is during arterial phase. This is the arterial phase. During arterial phase, a vein is enhanced. So it means there can be some arteriovenous malformation, or there is some connection from arteries. So there is early filling of the left renal vein, left gonadal vein. So that is why there is no enhancement on this side. However, there is enhancement here. You can see the whole area around the tumor. There is enhancement. It doesn't look like a peripheral enhancement. It is probably contrast leaking into the vein. Okay. So what are the different lesions which can present like this? One is AV malformation. There can be early venous opacification in arterial phase due to AV shunts, or and there can be thrombus also due to turbulent flow. Both is possible. But the point against is the mass is very large. So thrombus is usually they will not be that large in AV malformation. Primary vascular neomyosarcoma is a possibility. There is encasement intraluminal component. It arises from the venous wall, and cystic with remanagement is possibility. The possibility. Cystic with remanagement is there. However, the core biopsy is non-diagnostic for leiomyosarcoma. Organized bland thrombus is possible because of chronic history and no enhancement is there, but it is unlikely to have a thrombus of big size. Next is intravascular extension of a renal cell carcinoma or adrenal carcinoma, cortical carcinoma. It can grow along the vein. However, there is the kidney and adrenal are separate. They are completely normal. Next is a solitary fibrous tumor. So there is fibrous tumor with vascular affinity, can mimic vascular tumor on imaging. It is rare and typically not intravascular. However, here it is looking like intravascular. and biopsy is usually not diagnostic. So, what are the lesions which can demonstrate arteriovenous shunting, like the way this patient is having? AV malformations, AV fistulas, highly vascular tumors like Lenarson carcinoma, hepatocellular carcinoma, where there can be neovascularity, tumor neovascularity with bleeding into the, with AV type vessels inside. Hemangioma, tumor thrombus with neovascularity is also a possibility. Inflammatory pseudotumor or organizing hematoma, metastasis with vascular invasion. So my provisional diagnosis will be anatomically the lesion is in the left peritoneum, retroperitoneum, pararenal region, intraluminal endogonadal vein, left gonadal vein. Pathological probably it is needle cell tumor based on the biopsy report that is available. Biological behavior is a low grade malignancy because it is not enhancing. No enhancement is there on imaging. Etiology, maybe there is a vascular smooth muscle origin because that is one of the most common tumor coming in the gonadal vein or renal vein. Functionally, it is non-functional because there is no other symptoms patient is having or no other investigation done. Radiologically, it is hypoenhancing mass with early venous contrast pooling, vessel related, cystic areas are there, no clear invasion into the kidney. So the surgery was done. I think the treating team will come. I'll finish it. I'll finish it. Okay. Thank you. The surgical finding was there was a 6 centimeter solid cystic mass involving the left pararenal region near left renal hilum, mass abutting left renal vein and left ureter. Left gonadal vein was encased by the mass. Mass was closely abutting VJ flexor and tail of pancreas, and renal artery was free. Procedure performed was excision of left pararenal mass plus left ureteric repair, end-to-end anastomosis with 6 French DJ stent. Thank you. I would like to pathology. I still will tell that it is a tumor coming from the left renal vein with some vascular malformation. Biopsy is also telling a similar thing. And if we see critically the image, CT image, it looks like that. It is a tumor inside the left gonadal vein.
Thank you, sir, for the insightful and thorough discussion. Your approach in highlighting the closest differential to the case diagnosis. Spot on. Now, I invite audience for any differentials or any thought to share. I would like to now Dr. Naveen and his team to discuss how they worked on the case without revealing. Okay. Yes, ma'am.
Very nice and useful. Outside the way of this. As I see the stance, I agree with the thing that it is within the category, which is expanding the category. On CT, you are doubtful whether it is a solid cystic mass or it is a completely cystic mass with secretions. I moved the slides to MR. However, when we saw MR, we were more confident with the cystic nature of the mass. There was no solid component per se. And that was the whole point in doing MR. So it was showing multiple blood fluid levels and altered signal, which was showing that it is something vascular in origin, and probably the differential, one differential which we added was some lymphovascular kind of malformation. Because it was totally cystic, the enhancing secretions which were seen on CT were giving us curious of but here you can see blood fluid. MR actually planned us towards vascular malformation or illness which we can get the I don't think that we would have asked for the because it is not arising from the something to taking the kidney. It is not straddling, everyone's not seen separately. It has extension level in the vein, but not all the way to the vein it also functions unlikely.
Thank you, ma'am. Dr. Naveen Saran.
So initially the workup, so we discussed and the imaging was discussed in the radiological conference also. So it was dicey whether it's a lymphocyte malformation or it was a LMS, because we were worried about whether it's LMS or because on CT scan there was some microplastics inside, and the contrast obviously was pulling there. So that is why one of the differential diagnosis was LMS, and that was reported by the outside radiologist also. One of the differential was the LMS. Though the biopsy was inconclusive, so we thought that we would go for surgery. And as far as BTP is concerned, the BTP was done because there was possibility of nephrectomy. So it is our protocol before doing proceeding for any chance of any nephrectomy, we always do the BTP just for the renal function assessment, not for the tumor or tumor staging is concerned.
Because renal artery was displayed, said appearing based on the scan, they must have planned it.
So, working manager then there was any consideration of malignancy.
So there was a consideration of the malignancy because outsiders, all the images were done outside. PET scan, MRI, and CT scan. All the investigations suggested suspected case of malignancy.
So you attempted one biopsy.
Yes, because it was a vascular tumor, so we did not think about to go again for the biopsy. So it was resectable also.
Actually, the patient came to us with a biopsy done in private institute, and it has suggested a benign fibrocollagenous tissue and query malignancy also. So we have a doubt of malignancy, but imaging wise, as ma'am said, it showed like, and sir also said that it might be a angiogenic tumor or hematoma or any tumor arising from the blood vessels or AV shunts. So we repeated a biopsy here, and it also showed some benign disease. So we again went to our radiologist for radio conference, and we thought, and because there is an enhancing mass, we had a doubt that leiomyosarcoma, as Naveen said, there is a possibility of leiomyosarcoma. So we thought of going for surgery exploration, and for DTPA, since there is a very close abutment of renal vessels, so we would have thought of nephrectomy also. So we have this is our protocol to get a DTPA done because of legal complication. So we have done one for DTPA.
But like it
Pardon, sir?
is there.
It can be adrenal also.
No. Second row, first one. So there is a vessel. There are two vessels from the outer. So upper one is abutting the mass. So that is coming from outer, in front of outer. Left one. I saw the video. So it is coming from front of outer, anterolateral, going into the mass, and then it is very difficult to visualize further. Maybe it is a polar vessel. It is not visible. I tried it, but the section there is very thick.
It's not actively faced, difficult to place from
Yes,
there.
yes.
But we already knew that renal artery is anyways in close relationship. So he's right that they have to plan or they have to immediate nephrectomy. They will need.
I was asking whether that artery was ligated. Because if you see the video, let us go to the video. See the artery, this artery you can see. Above the renal artery, you can see another artery from outer. This one, here. Must have ligated it. this artery. It is blending here. Here it is blending. This one. Polar artery. Upper polar artery.
Thank you, sir. So we received a CT guided biopsy of left palpebral mass of 68-year-old female with a clinical history of no palpebral lung and differences of sarcoma, extremity asthma. So this biopsy predominantly composed of fibroid tissue and collagenous tissue, and there were vessels of variable caliber. But since the clinical differences were of LMS and RCC, so we thought maybe this lesion is a biopsy is a lesion, and we advised for a repeat biopsy. But we received a resection, and it was a well-labeled resection of retroabdominal mass. So this was a globular mass with solid appearance and surrounding retroabdominal adipose tissue. Surface was gelatinous and it was spongy and firm in consistency, and there was multiple cystically dilated spaces with blood filled and mucoid material. And there were no hard areas, no calcification, no necrosis seen grossly. On microscopy, this tumor was pretty much well circumscribed, but although not capsulated, and it showed large areas of degeneration in form of myxoid degeneration, cystic degeneration, and lots of stromal edema was there. And at places there was vague lobulated proliferation of the vascular channels. At places there were blood clot present. There were proliferation of smooth muscle bundles, and along with the capillary sized vascular proliferation, there were intermixed thin and thick walled vessels. At places there were cavernous like cystic spaces. So there was this sinusoidal pattern which was predominant along with anastomosing pattern, and then these vascular spaces, they were lined by bland endothelial cells which showed prominent hobnailing. There was no significant nuclear atypia. There was mild nuclear atypia, and the cells were ovoid to round. At places, they were showing intracytoplasmic hyaline globules. There was no mitosis. There were extravasated RBCs. And there were some areas where the cells were more ovoid to spindle shaped, with a few of them showing intracytoplasmic vacuolization. There were few foci of extramedullary hematopoiesis and fibrin thrombi. There were adipocytic metaplasia and smooth muscle proliferation. So the key morphological finding in this case was that this tumor was well circumscribed. There were vaguely lobulated proliferation of irregular capillary shaped vascular spaces, intermixed with thin and thick walled vessels. Predominant pattern was anastomosing and sinusoidal. There was prominent hobnailing. Extramedullary hematopoiesis, fibrin microthrombi, and extravasated RBC was seen. There was intracytoplasmic vacuoles and hyaline globules, and then there was smooth muscle proliferation and adipocytic metaplasia. What we didn't find was that there was no significant nuclear atypia, necrosis, mitosis, no multilayering of endothelial cells, no intralumen papillary tufts, no significant inflammatory infiltrate, atriovenous shunting, and no hemosiderin-laden macrophages, although there were lots of areas of hemorrhage. So based on these morphological findings, we categorized our differential into 4 groups. And the first possibility was vascular tumors with hemangioma, hemangioendothelioma, Kaposi sarcoma, cavernous lymphangioma, and well-differentiated angiosarcoma as the differentials. Angiomyolipoma, because there was this was looked like a triphasic tumor with adipocytic component, blood vessel, and muscle proliferation. Myopericytoma, angioliomyoma, glomangiomyoma, and least lower down the differential we had RCC with extensive hemangioma-like features or hemangioperisoma pericytoma, which is highly vascular. So we did IFC, and these cells they were positive for markers of endothelial differentiation, that is CD34, 31, and ERG. And out of these three, CD31 is more specific and sensitive for endothelial differentiation, as other two markers can be seen in other tumors also. And these cells were negative for SMA, which is a smooth muscle differentiation marker. The cells were negative for HTLS1, which is again a smooth muscle differentiation, and the cells were negative for melanin and HMB45. These two markers are for melanocytic differentiation, and cells were negative for pancytin. So, based on the immunohistochemistry, negativity of smooth muscle marker and melanocytic markers ruled out the differentials of angiomyolipoma, angiomyoma, cholangiomioma, and negativity of pancytin ruled out the possibility of any epithelial differentiation of the tumor. Imagine pericytoma is one of the tumors which show positivity for CD34, but is negative for other vascular markers, so it was also ruled out. So we were left with the vascular tumors. So we did further immunohistochemistry for HSV8. HSV8 is the immunoherpes virus 8, which is the most commonly used IFC for detecting the latent infection of immunoherpes virus. This tumor cells were negative for that. D240 is IFC marker for lymphatic phenotype. These cells were negative for D240. K67 was less than 2%. P53 showed wild expression. Kaposi sarcoma, they are invariably positive for HSV8, and lymphangiomas, they show D240 positivity. Well differentiated angiosarcoma, they usually have high Ki67 labeling index, and P53 is overexpressed. So based on the morphological features and this immunohistochemistry, we ruled out well differentiated angiosarcoma, Kaposi sarcoma, and lymphangioma. So we were left with hemangioma, Obnal hemangioendothelioma, and epithelioid hemangioendothelioma. So at this stage, it is important to differentiate epithelioid hemangioendothelioma because this is the malignant vascular tumor which has high risk of metastasis and recurrence. Although the morphology is not that characteristic for epithelioid hemangioendothelioma, because usually these tumors present as a solid nest of epithelioid cells. But there are subset of EHD which can show such prominent thin and thick walled vascular transformation, especially in subsets which show YAP1 and TAP3 gene fusion. So we did markers for to rule out EHE. Canta1 is a specific marker for EHE, and it was equivocal. So we went ahead with the FISH testing, which showed no gene rearrangement. TFP3 was done, and it was moderate but heterogeneous in staining, and so we did FISH testing, and there was again no gene rearrangement. So this ruled out the possibility of epithelioid hemangioendothelioma. So between these two hemangiomas and Hobnail hemangioendothelioma, Hobnail hemangioendotheliomas are the ones like petiform and Daxter's hemangioendothelioma, which are usually specific for skin and surface. They are hardly seen, or they are never seen in a deep-seated location. So, based on overall feature and history, the possibility of Hobnail hemangioendothelioma was ruled out. So, in hemangiomas also we had a few possibilities, like whether it is an anastomotic hemangioma, Hobnail hemangioma, cyanotic hemangioma, spindle cell hemangioma. Again, if we see spindle cell hemangioma, then it is a low-grade hemangioendothelioma which has a possibility of reoccurrence. So, it is important to rule out this entity as well. And for remaining three, they hardly reoccur, but still we need to differentiate between these three entities too. So these are the features which help us to differentiate. And in this case, what we could see was that there was extramedullary hematopoiesis, fibrin microthrombi, and adversarial component, which is usually not seen in the other three differentials. And but there was no intraluminal papillary ducts, no significant inflammatory infiltrate or mucosal-laden matter. So based on overall morphological feature, the possibility of these three were ruled out, and finally it was diagnosed as anastomotic hemangioma. So if we see the morphology again, there is a characteristic anastomotic and sinusoidal pattern with these vascular phases showing a prominent hobnailed endothelial cell. There was extramedullary hematopoiesis and fibrin microthrombi. So according to International Society for the Study of Vascular Anomalies, these vascular anomalies are divided into two groups, malformation and vascular tumors. And tumors are further classified into benign, intermediate, which include locally aggressive and rarely metastasizing, and malignant. So an astigmatic hemangioma is a type of capillary hemangioma which was first described by Montgomery and Ashton in 2009. They reported 6 cases of poorly recognized vascular tumors in the genitourinary tract, the predisposition for kidney, and had stimulating features of angiosarcoma. It is usually seen in the adult with mean age of 60 years, but lesions in pediatric age group have been reported. And most common site is kidney and retroperitoneal adipose tissue. But now the case reports have shown that these tumors seem to arise in female genital tract, GI tract, liver, brain, soft tissue, skin. Multifocality has been described. Mostly these lesions are small, 1 to 2 centimeter, but large size can be seen in non-renal lesions. So broadly, these lesions, anastomosing hemangiomas are divided into two types, renal and non-renal. For both the groups, the age is almost same, age of presentation, the middle age adult patient, and there is a male preponderance for renal cases. And in renal cases, it's the renal parenchyma where there is a usual localization seen, whereas in non-renal, it is the soft tissue bone. In that, it's the paraspinal area where these tumors are generally found. And the non-renal tumors, they are bigger as compared to the renal lesions. As there is no coexisting tumor or syndromes associated with anastomosing hemangiomas. According to previously reported cases, most of these patients, they had this as an incidental finding on imaging studies. And patients who had renal lesion, they usually present with hematuria or flank pain. So pathogenesis for an anastomosing hemangioma is not known, but there are studies which show that there is a recurrent GNAQ mutation in anastomosing hemangiomas. This GNAQ is basically a G protein which code for G alpha protein, which is needed for the activation of G protein coupled receptor. But this GNAQ mutation is not specific for anastomosing hemangiomas because this is the most commonly mutated gene in other vascular neoplasm. And not only vascular neoplasm, it is also seen in other malignancies like uveal melanoma and hepatic small cell neoplasm also. So on radiology, anastomosing hemangioma usually does not have any specific findings. CCT and MRI imaging cannot reliably differentiate anastomosing hemangioma from other aggressive neoplasm as angiosarcoma and renal cell carcinoma. This we have already discussed. So there was this interesting study which compared the anastomosing hemangioma with well-differentiated angiosarcoma, and this study showed that there is a molecular genetic difference between the two entities. And why it is important to differentiate anastomosing hemangioma from well-differentiated angiosarcoma, because both of these tumors are at a different spectrum with entirely different management. Because if it is an angiosarcoma, we go ahead with intensive chemo and radiation therapy, and also will have a bad prognosis, and there will be chances of recurrence. So it is important to differentiate the anastomosing hemangioma from a well-differentiated angiosarcoma. Prognosis wise, there is an excellent prognosis and it exhibits a benign biological behavior with no evidence of metastasis and recurrence after complete excision of the lesion. So there was only this single study which showed a long-term follow-up of a patient who was followed for 13 years and was disease-free. Treatment for anastomosing hemangiomas which are in renal, almost 90% of patients they undergo total nephrectomy, which shows that there is a tendency for over-treatment because of the inaccurate preoperative diagnosis. And whereas the non-renal anastomosing hemangiomas, they are simply excised with the preservation of the corresponding organ. So to summarize, anastomosing hemangioma is a rare benign vascular tumor that can closely mimic malignant lesions such as angiosarcoma and renal cell carcinoma, particularly in the kidney and retroperitoneum. Despite its alarming imaging and mixed morphological features, AH demonstrates benign behavior with no report recurrence or metastasis. Awareness of this entity and its accurate diagnosis achieved through careful histopathological evaluation and immunohistochemistry profiling is crucial to avoid misdiagnosis and unnecessary aggressive treatment. I would like to thank my seniors for their expert guidance and support in reporting and presenting this case, and Dr. Rachana for she's the faculty in charge, Dr. Shamini for this case, Pramod and Jyoti for their excellent technical work in immunohistochemistry fish testing, and Aditi for scanning slide with such a short span of time. Thank you.
Excellent description. I think you really hit the nail on the head. The doctor is most sticking in the mind is to do the lesions by hand. The second drawings were seen after a long time. I think they are what make the presentation more understandable. So I think giving a big hand
I would like to send Lisa and Lisa.
So this patient intraoperatively, since the lesion was arising from the gonadal vein, so it had an injury in the ureter. So we had prepared the ureter into and over the disease standing, and she had a ureter seal also. So the stent migrated in the ureter. So today her stent is removed and urology. Patient is fine, and we have kept her on the follow-up.
So I think Dr. Sandeep has already highlighted, and the most important thing as a clinician, like when we see the these kind of tumors, we always, being an oncologist, we always think that whether it's a tumor or it's a benign tumor. So sometimes if it is, even if it is a AV malformation, we have to think whether it's a tumor or not. Oncologically, how it is looks like benign or malignant. That is our challenging part that we always face, and sometimes, especially in the retroperitoneal sarcomas, biopsies does not contribute sometimes in few of the patients. So the diagnosis is very challenging. So that is why we went ahead for the case, because there was dicey whether it was a LMS or it was a AV malformation. Because if we see the clinical pattern and the prognosis wise, both are completely different. Because LMS is a very aggressive tumor, or the other like an angiosarcoma, one of the possibilities that it is also a very aggressive tumor. And if we compare with the hemangioma, it's completely benign. So that is why we went ahead for the surgery, and thankfully the surgery was uneventful. We were able to save the kidney that time, so that was the most important part in the surgery. Although the ureter was encased by the mass, so we resected and we anastomosed it. So that is the as far as clinical part is concerned. Maybe I think we can take comment from all the faculties, the pathologists.
actually patient came from
So sometimes it is very common in oncology. We always, the patient comes with a different complaint and, diagnosed with something else. She had prolapse, but that was
So we will refer the patient for gynecologist.
incident. It was incident.
Prolapse is there.
Because sir, the prolapse was not important for us. Important for us.
We'll send the patient for gynecologist.
Yes, please.
Nicely managed. One or two questions to the things are how the renal vein was because thrombus was lesion was going into the renal vein. So before ligating, have you clamped them or what?
Actually, what happened? The tumor was pushing the renal vein from inside, lower side. So on imaging, it is appearing that it is inside the tumor, but actually, the renal vein is pushed by the tumor from the below. So it was basically spread, though it is very close to the tumor, spread.
Another thing is what I would have done is maybe biopsy we could have avoided. Because leiomyosarcoma, you thought that is why.
Yeah, since the patient come to us with a biopsy which suggesting a fibrocollagen tissue only. So we have repeated
done.
already she has been biopsied in a private institute. Since one biopsy is suggesting a benign disease, so we reviewed it, it also showed benign disease, so we have gone for it because imaging wise it's malignant. And as an oncologist, as Naveen said, we just said that it is a malignant tumor, so we need a biopsy. And we thought of some lymphoma also. It is coming as benign and lymphoma came out, it can be treated by the chemotherapy.
Sorry, I saw the CT. I think radiologist is there. CT was very interesting when I had the clip from it. That was not very good visible, so I transferred to send me the video. After seeing the video, then I could think. Otherwise, I would have thought also same. Leiomyosarcoma or pheochromocytoma, anything is possible. Okay, thank you.
Thank you all for your valuable contribution. I appreciate everyone's time and insight during this discussion. A special thank to Dr. Dilip sir for his expert approach in identifying the differences and ultimately reaching the diagnosis. We look forward to next episode. Thank you.